Should I start? Okay. Welcome to the Australian Intercultural Society webinar, COVID-19, its impact on the Australian healthcare system and where to from here. My name is Dr. Leslie Cannold, and I'm an author, an educator, a medical ethicist, and a board member. And today we're having a conversation with Professor Erwin Loh. But before I introduce Professor Loh, and before we kick off, I want to start by acknowledging the traditional custodians of all the lands of Australia and pay my respects to their elders and emerging leaders past and present. This is and always has been Aboriginal land. I also want to encourage all of you to use the chat function, which should be to the right of your YouTube screen. Send questions through anytime. I'll also remind you at the end where we will focus a little bit more on questions, but if you send them through as we're talking, that's absolutely fine. It's really good. I will try to integrate them absolutely seamlessly into the questions that I'm asking Professor Loh. We're planning to talk to you for around half an hour and then take questions for about 10 minutes. We don't want to go much longer than 40 minutes. If you need to be back at work by 1, I promise you I will get you there. So let's start. You have to talk about what a ride this whole thing has been with the COVID-19. Since early March this year, Australians and the whole world have really been reeling from the impact of this novel coronavirus, which seems to have found its way from animals to humans at a seafood market in Wuhan, China, somewhere back in November or December last year. Since then, we've had 3 million cases in almost every country in the world, and there's been more than 205,000 people who have died, some alone in overwhelmed healthcare systems where doctors and nurses have been forced to ration critical care resources like ventilators and to reuse personal protective equipment that they need to keep themselves and their families safe. We've seen this in Italy, Spain, and now parts of the US, the latest epicenter of the pandemic, that just yesterday recorded close to 40,000 new cases, a figure that may be an underestimate because of the inadequacy of testing, and that appears to be growing. Yet elsewhere around the globe, there are signs of hope. South Korea, China, and a number of European countries, Germany amongst them, have begun to ease the social distancing measures that in the absence of both vaccine and treatment are all we have in our toolkit right now to keep safe. There is light at the end of the tunnel here in Australia and across the ditch in New Zealand too, as transmission rates approach or dip below the magic figure of 1, and states like West Australia and Queensland start to ease the restrictions on our movements that have hurt our economy, pinioned our children's educations, and tested all of our mental health. Soon, perhaps, much sooner than we anticipated, we could be returning, at least within our own closed borders, to something that might resemble normal. Which makes this a perfect time to profit from the wisdom and experience of Professor Erwin Loh. Professor Erwin Loh is a National Chief Medical Officer and Group General Manager of Clinical Governance for St Vincent's Health Australia. St Vincent's Health Australia is the nation's largest not-for-profit health and aged care provider. It has 36 facilities, including 6 public hospitals, 9 private hospitals, and 17 aged care facilities in Queensland, New South Wales, and Victoria. It also has 3 co-located research institutes, which include the Victor Chang Cardiac Research Institute, the Garvan Institute of Medical Research, and St Vincent's Institute of Medical Research. Erwin has been at the epicenter of preparing St. V's for the potential onslaught of the virus on our shores. He's been managing cases, and now he's been thinking about and making decisions required for us to transition back to wherever we're headed. So Erwin, welcome.
Thank you, Leslie.
It's really a pleasure to have you. So let's just start by setting the scene a little and looking back. So mostly we're going to forward face today, but I really wanted to kind of take us back, which it seems like a million years ago, but it actually was probably only for the most of us in March. It may have been earlier for you. When did you first hear about this novel coronavirus we're now calling COVID-19? And when did you realize the challenge that the healthcare system and the healthcare system you're managing was going to be facing?
Okay, so COVID-19 hit the news around December. If you remember, there was already in December, around Christmas time, news reports of atypical pneumonia infections being emitted in hospitals in China, in Wuhan, the Hubei province. And at the time, people were wondering whether this was going to be similar to SARS, if you remember. So there was a discussion about new pneumonia. What is it? They didn't know it was coronavirus at the time, but there were questions asked. It was really around early January that some of the medical staff in Wuhan started leaking reports of a lot of patients being unwell, and there were some well-known cases around those doctors. And it was around that time that I got concerned. So we started looking at it. I started looking at it personally, tracking it, because then reports came out that it is a coronavirus. It is similar to SARS, and people were really worried that this would not be contained by China. If you remember, the World Health Organization at the time were a bit optimistic that China, because they really ran hard. It was around, if you recall, Chinese New Year, and there was a lot of concern that the Chinese would, as they move around the country for Chinese New Year, they would be spreading the virus beyond Wuhan. So,
and Erwin, what was the particular concern about a coronavirus? Why does that sort of send flags up?
Well, first of all, everyone remembers 2009 SARS epidemic that happened at the time, where it was a coronavirus, and it went beyond Hong Kong, China, Hong Kong at the time, and went through, killed about over 700 people, and it was because of people's strong public health measures that it got shut down. But people remember that. And coronaviruses are also cold viruses. There are a few strains that go around every year, and they can be contagious. And so the worry about a pandemic is, that would spread around the world, that would have a huge impact from a health point of view, would be viruses that are influenza viruses. But a coronavirus has been thought about. Even a few months before this happened, people had written a study postulating that a global pandemic could be caused by a coronavirus. So coronavirus has always been a candidate for a pandemic contagion. So that was the thinking. And
what was your worst nightmare? Like when you started realizing this was coming to Australia, it was here, what were you most worried about in terms of our health system keeping up?
Well, I think at the time, we were praying really hard that the draconian measures that the Chinese government were putting into place was going to work. It was going to shut it down. And it looked as though it was working. So the worst nightmare was that the virus breaches containment within China and spreads around the world. At the time, the mortality rate looked really bad. I mean, it was like, now we know it's sitting around 1% or maybe less. But at the time, it was 10%. I mean, there were a lot of people dying of the virus just because of the lack of testing in the general population at the time. So it looked bad. It looked like it was killing a lot of people and looked to be contagious. But we didn't have much information really beyond that. So it was really concerning that if this got out of the country, it could be a global pandemic that could kill a lot of people, like what the Spanish influenza pandemic did. So that was my worst nightmare. And in one sense, it is the worst nightmare is the reality. It has spread around the world now. It has become a pandemic. At the time, if you remember, the only flights out of Wuhan were landing in Sydney. So the Australian government initially, for the first few days, allowed the flights to come into Sydney. If you remember, they did temperature checking, but very, very quickly, our government stopped flights out of China completely against the advice of the World Health Organization as it happened.
Right. When did we realize that it was here, and what did your hospital system and the hospital systems in generally start to do to prepare?
So even before we were looking at the flights out of Wuhan, the St Vincent and a lot of the states, I mean, Australia already had declared it a pandemic initially. They kicked in the pandemic response plan, and from the Commonwealth point of view. A few days before that, we had already formed at St Vincent's a task force to start to plan on how we would respond. Our hospital in Sydney was already working with the Ministry of Health in New South Wales in relation to receiving patients, if any, from Wuhan, because the government had already anticipated, if you're going to get flights from Wuhan, if there was going to be a positive case, which hospitals would they go to? So Westmead was the designated hospital, but Sydney Public Hospital.
So are we in February now, or are we in March?
No,
where are we?
By then, I think we would be by then in February, March. We would be probably by this point, early March. So January, there's a lot happening. February, everyone was getting concerned. March, pandemic was declared by Australia, looking at Wuhan, and then the lockdown happened mid-March.
And what's the big concern at the time, that Australia was not going to have enough ICU beds? Was the concern about PPE, personal protective equipment? What kinds of things were you thinking about in terms of preparing our system?
So it was all of the above, really. So the advantage that Australia has had is that we are in the Southern Hemisphere. We are geographically located on an island continent, a bit far away removed from the rest of the world. And that has allowed us to learn from what's going on in the Northern Hemisphere, because they went through the wintertime as the pandemic was evolving and spreading. So, and wintertime is when respiratory infectious diseases spread the most. So we got the opportunity to look at what was going on in Italy. So Italy, if you recall, China, and then Italy, and then Iran, and then South Korea were the first 4 countries that we banned as the country. And they were the kind of hotspots initially. And you can actually see how each country had kind of went on different trajectories. So we managed to learn from that. We learned from Italy's experience, we learned from South Korea's experience. And then as it happened—
What did we learn? So from Italy, we learned what?
Well, we learned, as you were mentioning, that very easily, if you did not control the initial outbreak, it could get out of control and very easily overwhelm your health system. So this is all the discussion around flattening the curve, the curve being the number of patients that would spike up and surge up. And if the peak happens too quickly and if too many patients present to your hospital system as a country, it can overwhelm your ability to admit them to the hospital wards, but also into ICU. And that's when you have a high mortality rate. And this is when people die, because lacking any treatment, lacking any vaccine, it means that all we can do if you get COVID-19 is to treat you symptomatically. And that means if you get the pneumonia version of it, your lungs get flooded with fluids, you can't breathe, you need oxygen pushed into your lungs, either through a mask, or if you need to, mechanical ventilation, and you need intubation. And
so you canceled elective surgery. I know that was one thing that happened. What other kind of things were happening in the hospital system to get ready for what kind of number of cases? How many cases did you think you were going to have?
Yeah, so modeling was happening at the national level, but then other different states were also doing their own modeling. So we kind of had a worst case scenario, and then a best case scenario, and then everything in between. And we clearly, as you want to plan for the worst and hope for the best. So we were planning for the worst case scenario. So as a country, we had to double our ICU capacity. We had 2,200 beds, ICU beds. We wanted to double it to 5,000. And so there was planning across the different states to look at that. So we played our part. So St Vincent, South Australia, our different facilities across the country were working together with the state's public health units in contributing to the state pandemic responses. So if you look at what we had to do, there were a few things, right? So you can divide it into six kind of components. So at the top is to comply with government measures around social distancing or physical distancing and infection control. So this is promoting within the hospitals and with our staff and our patients and the families and the community, making sure we've got distancing, making sure everyone's washing their hands, infection control, cleaning surfaces. So that's important. Then the second thing which you alluded to is the surge response. So if there was to be a surge as a worst case scenario, we need to ensure that we have enough beds, we have enough manpower, enough PPE, so personal protective equipment, to manage that surge. So all of that is then to do with, so you need to make sure you have enough hospital beds. How do you do that? You have to cancel non-urgent admissions. All the elective surgery that we do, that we plan to do, we cancel or postpone really to free up beds. And by freeing up beds, you free up ICU beds. And so we also increase the number of ICU beds. How can we actually expand ICU into our operating theaters, into our recovery rooms, into some of our wards? How do we repurpose some of our wards so that they can be not upskilled, but changed and transformed to be ICU-like to support the potential. We also needed then to manage our workforce, which is a huge part of this whole response, which is our third component, is reskilling staff, repurposing them, credentialing them so that if retired doctors and nurses and medical students and nursing students are upskilled, we have a system to train them and support and supervise them. We needed to do modeling to see if staff became unwell, because we anticipate that certain numbers of staff, a proportion of them will become unwell with COVID-19 or other things. How do we fill that gap? How do we move people from different specialties into other specialties? All of that had to be looked at. So that's workforce modeling number 3. But part of that workforce modeling is related to that is IT infrastructure. So we needed to upgrade our information technology, networking capabilities for allow people to work from home, to allow people to work remotely. All of that had to be done. The fifth thing that we did as well is supply chain management. And this is where the PPE issue comes in. So we knew that there are a few issues here, right? First of all, China manufactures a lot of our PPE, as well as our medications and other medical equipment. So when China went offline, we needed to find alternative sources. This is one of the things to do with globalization, so that's one thing. But then we also knew that with COVID-19 being a pandemic worldwide, every other country was buying up personal protective equipment, masks, gowns, gloves, but they were also buying up ventilators, all sorts of other equipment. So we, as a government, but also as a group, as a company, we had to kind of find our own sources. And so that had to be done. But then the third issue is then quality. So you would have read in the media, a lot of the consumables and test kits, even PPE from certain places like China and India were not of the right quality. So we had to also then start to make sure that we get the right source and have a supply chain going. So that was a huge piece of work that we did as a group, as a company, but also the country and the states have been doing as well. So in fact, we were competing with.
Yeah. And then my understanding is what happens, because I sit on a nurses board, and so I was interacting with all the nurses, is that everyone's then waiting, feeling like it's the calm before the storm, and that in any minute now you're going to get hit, but the hit never comes. Is that right?
Well, it hasn't come at the moment, and that's essentially because if you look at just the Australian Bureau of Statistics did a survey, and this was last week, and they found that 98% of Australians that they surveyed were complying with the physical distancing measures.
Wait a minute, wait, 98%?
98%. So
that's extraordinary.
It is extraordinary, and that's a testament to the community spirit of Australians. They stepped up. They said that they're going to do this not only for themselves, but for the vulnerable and the elderly people in the community. And they followed the rules. I mean, you have a small.
Because the modeling was saying 80%. You had to get just 80%
That's
compliance.
right. That's right. But we went above and beyond. So that meant that we flattened the curve. And in fact, we didn't just flatten it, we basically crushed it. Like we not seeking an elimination strategy, we practically almost eliminated it. You know, our results are similar to New Zealand. If you look at per capita in terms of results, we did just as well as New Zealand. In fact, some people say we have done better than New Zealand, and they went down an elimination strategy. We were suppressing it. And so we've done well. And thanks to that, we have, so if you look at the curve, which was not done like that, we pushed it down. So then that doesn't mean we were not going to get a peak, right? So remember, two things. One, we're heading towards winter. And it's during winter when we get influenza, although influenza levels are down as well because we have physical distancing in place. During winter is when you expect something like this to increase. So we need to plan for an increase. But also, the government is now looking at loosening restrictions. Now, as you loosen restrictions, we will see an increase. We will see an uptick in cases and potentially in deaths. And as a community, as a society, that's what we need to titrate, is at what level can we increase our restrictions to improve the economy, but to an extent where we do not overwhelm the health system, that we can tolerate people getting sick, we will have beds for them, they can go into ICU and they'll get better, so that we do not get to a point where the health system's overwhelmed and we run out of ICU beds. That's when people start to die, because people will survive if they can get an ICU bed and be supported. And if they support over a few weeks, yeah.
Are you saying that, because one thing that was really noticeable about Australian figures, in addition to, as you say, this kind of extraordinary rate of compliance and this doing better than we even thought we could do in terms of suppressing the virus to the point where it looks like there's a possibility around elimination, and I'll ask you about that debate in a minute. But one thing that's also been so noticeable is that our death rate has been so low. So according to the Prime Minister, it's been around 100 times lower than France and the UK, 50 times lower than in the US, and 20 times lower than Germany. So are you saying that all comes down to the fact that we have had more than adequate ICU beds and people who know how to treat people in intensive care?
So it's all about math, right? It's math. So we know, roughly speaking, that 1% of the population who catch COVID-19 will die. It's 1%. And so that's with giving them all the appropriate care, right? So because we've flattened the curve to reduce the number of people catching COVID-19, we've had the 1% dying, right? And that number can be debated because it depends on how many people you test, asymptomatic cases, all of that. Now, if the reason why, if you look at Italy, the mortality rate's gone up to 7%, 6-7% in the UK, as well as higher than the 1%. It's because they just hit the capacity to treat people. In Italy, for example, at the peak of the surge, they had insufficient ICU beds. So they were making really difficult ethical decisions to not admit, for example, anyone over 65. So you're over 65, you're not going to go into ICU. So these were the hard decisions.
They were rationing healthcare. It was a nightmare.
They were rationing healthcare. Yeah, that's right. Yeah. And this is why when you look at the studies in Italy, for example, they had a high proportion of people under 60 in ICU. They had 40 and 50-year-olds. That's because that was the only way you could get into ICU, was to be younger. So we never got to that point in Australia, and touch wood, we'll never get to the point because
let's talk about that, because what you were saying was winter's coming. It might be, that as we loosen up restrictions, we are going to see more infections, and we're going to have to find this sort of sweet spot of kind of how much we're willing to tolerate and get, how we balance our freedoms and the rate of people getting sick and the 1% getting so sick that they get seriously ill and die. But what about elimination? So in New Zealand, they are consciously pursuing a strategy of elimination. We have a government that's saying that that's not what we're doing. And yet we also have people like Stephen Duckett at the Grattan Institute suggesting that we have just done so extraordinarily well. Why shouldn't we be thinking about elimination so that we don't have to think about, pushing the pressure on the health system over to the right, but rather go back to normal within our own borders.
It's an attractive strategy, elimination, because if you think about it logically, if you can eliminate the virus within our borders, we can then keep our borders still restricted, but then just open up everything internally, because you won't have a virus to worry about. We can just live our lives like normal. The only reason why the experts advising the Australian government are not recommending that we go down this route is essentially because elimination is really difficult. And even for New Zealand, which is a small country, 5 million people, they've locked down, stage 4, it's not clear that they can ever achieve elimination, because as you and I know, all it takes is one person with the virus to restart the whole outbreak again. So you need to be confident that you completely extinguish the virus.
Which means you need lots of surveillance testing.
That's not enough. You just need to.
That's not even enough.
It needs to be zero virus in the country.
And so how would you practically try to pursue zero virus? Surely you'd have to have lots of surveillance testing, but what else?
Well, ultimately, how does the virus die? It dies by having no host to jump to, right? Which is the theory behind social distancing. If everyone stays at home and locks down, if you and I lock ourselves up, if every human being in Australia locks themselves up in a room for 2 weeks straight and do not talk to anybody, the virus will die. It will just disappear. But that's not practical. I mean, we can't live like that. And so and we haven't done that in Australia. We haven't gone to stage 4. We've gone to stage 3 in stage 3 lockdown in Victoria. New Zealand's gone to stage 4, but even then, they still allow people to go grocery shopping. So that's when the viruses can still skip around. So they are actually this week going to stage 3. They're loosening restrictions already. So I think the strategy in Australia is that they're not aiming for elimination, because to do that consciously, you really need to sacrifice the economy, right? You really have to say lockdown. Really go to stage 4, have the police and military involved, and really lock everyone down. They haven't decided to do that, but they are saying though that if elimination is a byproduct of a suppression strategy, fantastic. So, and that's what the Grattan Institute is saying. They're saying they're suggesting, look, we've already gone down to stage 3. If you wait it out for another 2 weeks to a month, maybe elimination is a side effect of that.
Okay.
I think the experts are saying, great, yes, we could do that, but the probability of it being successful is highly unlikely, because like I was saying, it just takes one person with the virus. I mean,
exactly.
So
suppression or elimination. Yeah. Suppression or elimination is really going to be with us as this new normal, at least with closed borders. So if we start thinking about how can we actually ever get back to some sort of life as we knew it, which would include not having closed borders and mandatory quarantine, which is what happens now when people are returning, for instance, to Australia, who've been stuck outside of the country. They're going into mandatory quarantine or isolation for 14 days. How can we get back to something that's not like that? That means we need either an effective treatment or better still, a vaccine. What is your kind of expert thinking at the moment about how close we are to one, other, or both of those things?
Sure. So I should mention, so you brought up the vaccine. So this is another reason why elimination, it's going to be a difficult goal to aim for without a vaccine. So if you knew a vaccine was coming, you could lock down the country for 6 months, keep down the deaths and things, because a vaccine was coming and was a guarantee. At the moment, there is actually no guarantee. I mean, Oxford and a few other places are now doing human testing now. And there's a lot of optimistic views that, maybe by September, October, very quickly, we may have a functional vaccine. But there is no guarantee. We've never been successful in getting a coronavirus vaccine over the past 20 years. It's hard. There are particular quirks about this particular virus. So without a vaccine on the horizon, we're working on it. I mean, we're working on treatments. As you say, at some point, we'll have to learn to live with the virus while we wait for effective treatment or vaccine. So we kind of need to figure out how we can live our lives, restart the economy while maintaining some measures to keep the curve as flat as possible. So we've done very well. We just have to find out when. So in my view, we will probably come up with some treatments. There's a lot of work happening. There are different antivirals. There is plasma transfusions that seem to be working. So there are some.
Is that where you give people antibodies from people who've had it and
that's
successfully
right.
fought it off?
Exactly.
Right.
They've done it in South Korea. They're in China. They're doing some trials in the US, and the preliminary results are promising. So that's great. They're also doing a lot of studies around monoclonal antibodies. So immunotherapy is something they're looking at. So they're good signs. On the vaccine front, there are now over 100 programs. This is probably the most vaccine development. People are putting in billions of dollars. So we will see some results, but whether it's going to be effective, because part of the issue here, and the World Health Organization just came up with a report over the weekend, there's no guarantee that even if you catch this virus, you will have an immune response that gives you immunity in the long term. There's the World Health report saying, the World Health Organization saying, current evidence suggests that you do not have that. There's no guarantee. There are a lot.
So in other words, the immunity you get, whether you have it or whether it's provoked by a vaccine, is unlikely to last very long. And therefore, even if a vaccine comes, you'd have to keep getting the vaccine.
The vaccine has to be designed to induce an immune response in the right cells. At the moment, the virus does it. We don't develop a strong memory. Coronaviruses in general don't do that anyway. So it might be that you get, because there are now over 140 people, in fact, over 600 now in South Korea. I was reading the latest article of people who've had the virus, positive, then they got better, they tested negative, and now they're testing positive again. They become unwell again and tested positive again, right? And then
so that's immunity that's not even lasting 4 weeks, 6 weeks.
Well, months maybe. They're not sure whether it's a reinfection or reactivation of the virus. No one's really clear. There's a lot about this virus that we're still not clear about. So, so this is what I'm saying, the immune response. So all this discussion about antibody testing, so the World Health Organization report specifically talks about that. Some countries talking about how some countries like Germany, the UK, Ireland are looking at doing antibody testing and giving people an immunity passport to say, oh yeah, you've had the virus, you are immune. The World Health Organization is cautioning to say, you might not be immune. That might give you a false sense of security. So that's evolving. So that's bit,
it's complicated, very complicated. So look, I'm going to remind people that they can send in questions. I'm going to ask you one more, Erwin, and then I'm going to go to our listeners' questions. My last question is around the contact tracing app. So you've described very well the kind of obstacles we face in terms of how it is we're going to even get Australia with closed borders up and running, especially if we try to go for an elimination strategy. Where do you see the contact tracing app that has been launched today and that the government is advocating that apparently already 1 million of us have downloaded it? Yes. The government is advocating that, as many of us as possible do so. Where do you stand on that about why, if it's going to be helpful, how it's going to be helpful, and if we should download it?
Sure. So my view and my recommendation for anyone listening is that we can all play our part by installing the app, and I'll explain why. So the government's been saying that the app is going to help the government decide how much they can loosen the restrictions, and that's really because the app, it's a cut down version of the Singaporean app, but cut down by a lot. So that all it does, so it doesn't have any GPS, anything like that. All it does is it records your phone number, and then if other people have installed the app, it will their phone come close to your phone, it will record the other person's phone number, and that's it. So you can put in false names, they don't really care. And the reason being, at the moment, with our restrictions, we kind of have an idea of who we're in contact with, right? More or less. Although when you go to the grocery stores or you go to Bunnings, there are lots of strangers around. as the government loosens restrictions, we're going to be going to public areas more where you're going to be passing by people you don't know. But the app will be collecting the information. Now, if one of those strangers develops symptoms and they get tested and they're positive, and they have the app, they have to tell the public health officials that they have been confirmed. And what happens then is that the public health officials, they have to do contact tracing. That's what they do today, right? In the past, they would interview the person and say, where did you go? Who did you talk to? And then they'll have traced steps back to find out who they were. But if they've been to a supermarket, they're not going to know who they walked past.
Right, you miss the casual contacts.
That's right. However, if everyone's got the app, the public health expert will be able to contact trace. Because all they'll do is download the list of phone numbers that have been close to that phone. They will call you and I, because we had walked past a person and say, hey, you were at Coles the other day. You walked past someone who's now tested positive. Did you talk to anybody? Did anyone cough on you? And they'll be able to tell you. So you and I will know, actually, we walked past the person, but they will know if the risk was high or low, whether we need to be tested, whether we need to self-isolate. So it actually helps everybody for contact tracing. So the specific purpose is that it bolsters up our ability to contact, so that it gives the government confidence to open up more. So because the more they open up, the less easy it is to do contact tracing, to be honest, because you'll be going around everywhere. And by being able to
this allows us to open up more because we can do the effective contact tracing
and
with people who we wouldn't otherwise know the names of, and therefore know that we had been in contact with.
Be able to shut down outbreaks. They'll be able to trace how someone's caught it and shut down everyone who he walked past. We could isolate and then keep everyone else safe. And if we have been exposed, we will know about it. We will self-isolate and then protect our family and friends ourselves. Because, or if we catch it, then we can, it's that reason. It's not.
It makes sense.
And there's no ability to GPS you to see where you've been. It's just proximity to people. That's how it's meant to work.
And of course, what people are always worried about with this sort of thing is function creep, and they're worried about privacy. But I think what the debate has been around has been this very complicated thing about other liberties that we want, which is we want freedom. And so in some ways, this is trying to kind of take a little bit off of privacy in order to give all of us back some freedom. And obviously, every individual is going to have to make decisions around how they want to trade those very, very important civil liberties off. But certainly, we have already undergone such serious restrictions in our civil liberties, haven't we, with all of us, being compelled to work at home and being compelled to stay at home. So the debate is such an interesting one to have, and we could have an entirely separate conversation just about that. So what I'll do is I'll focus now on some of the questions that our listeners have for you. This is a very important question, and one I was going to ask. So thank you to the viewer who's asked this one. What are your thoughts, Erwin, about schools, about the government opening schools? The federal government at the moment, as we know, is saying, yes, the schools should be open. This has been an area in which the states have been really at loggerheads with the government from the start. So what do you think about the safety for kids, although it looks like we do know that children don't seem to be big spreaders or who get the virus in any way that's serious? Most don't anyway. But what do we know about parents being home and the way that they traffic with one another, both as teachers and as parents, in terms of drop off and that sort of thing?
So the school debate is an interesting one. And I think, it's in my view is, if you put schools aside and just take a holistic approach to the strategy that we want to move forward as a society. So if we believe now that we have flattened the curve sufficiently enough that we can afford to start to loosen restrictions as a country, as a community, how should we do so? So if you look at the principles of loosening restrictions, one of the principles would be you look at the different demographics of the population and look at which cohort in our population is least vulnerable, they will be the ones who we can loosen restrictions around first. The elderly, the people with the chronic disease, who are people with cancer, immunocompromised, they should be the last, right? So we would agree on that. So if you approach it using that principle, we would think if children are the least vulnerable, and we know that if you look at the stats in terms of who catches it, although there's a bias, right? Because it's all to do with confirmed. We don't test kids, so obviously the numbers are lower.
Goes back to surveillance testing.
Yeah, but that's because they get a mild version. Most kids get the cough, maybe a fever, but then they get over it, like they do with a lot of viral illnesses. So they are least vulnerable, they have least mortality. So some of the experts would argue, if you had to loosen up, then it would make sense to open up schools for really three reasons. Number one, they're least vulnerable. Number two, to create some level of herd immunity. I mean, it's not enough to stop the virus, but if kids get it and they get a mild disease, there's some level of immunity. And number three, this has been argued before, it allows for people to go back to work, like, essential workers, but also other people, parents now have to stay at home. So it kind of creates that economy kind of impact. So that's why, right? Now, the converse argument is that, they will bring it back to the parents. So that's true. There is that potential transmission to parents and teachers as well, which is why, although kids are less vulnerable, teachers still have to have the social distancing as they work, as all of us should anyway, when we all go to work. But there is that potential risk to parents. That is a known risk. So right. like I was saying, though, with any loosening of restrictions, there is that risk. So
that's right. And so the question is this the priority for us, given the fact that we need to open something up?
You're going to open something up.
Will it be schools?
So you do schools, you might do universities and colleges, then you might do some kind of essential manufacturing kind of work, and the last would be the elderly, but also, non-essential entertainment type things like sporting events and concerts. You do that last because they're not important, not essential as a community. Well, I mean, people argue.
Well, isn't the big problem with things like movie theaters and sporting venues is that, the contact tracing app is obviously trying to work with this, but you can have contact with so many people and you won't know who they are. And therefore, if someone is spreading, they can spread to a lot of people and they'll be difficult to trace.
Absolutely. Yes. So, yes.
Okay.
So hopefully
we've got some other questions for you here. One person has wanted to know, how do health professionals feel about being on the front lines, knowing they could be infected and potentially unknowingly spread COVID to their loved ones? What goes on in your minds?
So the frontline, so a few things. First of all, frontline clinicians, they do their jobs because that's their job. They're trained to go to work, care for people, and they do that day in and day out. And so whether it's COVID-19 or whether it's anything else, influenza, any types of, any other epidemics. So that's the first thing to say. And clearly they are human beings, and so they will have their own fears and anxieties. So if you look at the experience overseas, which our own clinicians here in Australia have looked at and have learned from, but also their friends overseas as well who go through this and experience this, they see that their colleagues overseas have not been given sufficient personal protective equipment. They've fallen sick. Some of them have died. There's been quite they are overrepresented in the number of people who get infected, and they've died. And they've
been forced to ration care, which is a nightmare.
Forced to ration care, which gives them moral dilemmas, and so their own psychological injuries and mental health. The mental health burden of that is huge. So they've seen that, and so clearly they have their own anxieties, but they will still come to work. And from that point of view, of course, what happens if they get infected and they spread it? I think the first principle here is that we need to support our frontline clinicians and keep them safe. So that's number one, right? No question. So that means then we need to protect them physically. We need to make sure that they get the right equipment at the right time. We have a supplier. That's secondly, we need to support them from the mental health point of view, because we know that the toll on the emotional well-being is huge. So we need to give them access to all that. The belief, and this is from the research and from experience overseas, Hong Kong, China, is that if they're given the right personal protective equipment and they use it correctly, they won't catch this illness or any other illness.
Great.
I mean,
right.
it
protects them.
Of course. I mean, and when I spoke to some specialists from Hong Kong recently about the experience, and one of the this is with a bunch of doctors, and one of the intensive care specialists asked the ICU specialist from Hong Kong, do you have a lot of staff catching this and dying? And he said none, literally none. They're saying because all the cases, I mean, they only had a handful, all the cases of staff catching it from patients is when there was a breach in policy. And to be honest, it's not easy. Putting on PPE, and so donning and doffing, which is taking it off, that in particular doffing, when you take it off, that's the highest risk for clinicians, because you, especially when you're tired, you've had a long shift, you make mistakes. You touch your face, you just take something off in the wrong way. And this is why it's so important to do it properly, to be trained, to have a buddy system where you watch someone else take theirs off and they watch you so that you follow the steps. Or you take a mistake.
Is that all happening in Australia? All of those things that we have enough, people are buddying, they're taking it on and off properly, they're getting mental health support. So is that happening?
At the moment, we believe we have enough from a Commonwealth point of view and the state stockpiles. And even in St Vincent, we have our own internal company stockpile. We believe we have enough. It's a bit unpredictable. We have enough for now to accommodate the surge according to the state guidelines, but things will change. We have backup plans. For example, we have looked at recycling PPE, not best practice, but worst case scenario, how do we sterilize masks and reuse them? There is research from overseas on how to do that, and we're exploring that, and the states are exploring that. So
have any Australian health workers been infected?
Well, there has been cases of Australian health workers catching it from patients in ICU, and sort of sporadic cases, not many, zero in St Vincent's, but in other hospitals that has happened. Yeah.
Okay. Well, I mean,
I
think that's why everyone's feeling like, the profession is, as you say, doing their job. This is what you're trained to do. The firefighters have to run into burning buildings, and health professionals have to take health risks, but still, I think it's very appreciated by the community.
But we just have to make sure they have the right equipment. I mean, I completely support that. They need to be confident that there's that access. Yeah.
Yes. So this will be our last question, because I do appreciate that it's a hard thing for people to keep sitting through for such a long period of time. But it's been a great discussion, Erwin. People are really enjoying it. We've got lots of great questions. I want to ask you, this last question is, it appears that zero COVID-19 cases would be impossible as international travel would occur. So I assume what that person means is, even if we got to zero, eventually we'd have to open our borders and there would be people who would come in. So without a vaccine, what kind of levels would we accept? Sure. But I guess what I'd want to add to that question is, don't we quarantine people when they come in? So
correct. Yes. I'll just kind of, there's a nuance here. This is the difference between elimination and eradication. So people have used those terms interchangeably, but in public health, they mean different things, right? So we can, if we really wanted to, eliminate a disease within a country. So elimination refers to getting a case of a disease down to zero in a particular area. Could be a country.
So Australia has zero cases.
Yeah, that's elimination in Australia. Eradication, on the other hand, is what we've done with smallpox. Right? It's where you have an efficient vaccine.
Which means there's no cases in the world.
In the world, eradication is an international goal. Elimination is more a national goal. So that person is correct. If you can eliminate it here in Australia, you can have, quarantining people coming from overseas, everybody in hotels and things. You can't trust them at home, right? We tried that. It doesn't work. People
didn't work.
yeah. So you kind of have to lock them up somewhere. And that might work. That, all it takes is one case, like I said, to let it out. But that might work. But it is difficult. I mean, especially now. This is the thing here. What if we never get a vaccine? Then we'll have to learn to live with this, like we learned to live with influenza and other illnesses, right? We'll have to come up with a way to kind of live with this long term, forever.
And that's kind of what they're doing in Sweden at the moment, isn't it? That at the moment in Sweden, they're basically saying, we're never going to get rid of it because, of course, there's much higher case levels and therefore much higher sort of community transmission in European countries. People who are asymptomatic, they've decided they're never going to get to an elimination like New Zealand and Australia could potentially. So they have to just learn to live with it. And therefore, they're trying to find this sweet spot of kind of social distancing management techniques that, as you say, kind of just control the rate at which people get super ill, end up in hospital, and manage it at that level.
So it's a fascinating theory, and it'll be interesting to watch them over time, because this is a real life experiment that we can look at, because they're like a control group and we are like the experimental group, and different countries are using different studies. It's fascinating because their theory is that it's not like they're not doing anything. They have social distancing measures, but voluntarily, really low level, no groups over 50, low level. So, but they're aiming for herd immunity. It is a high risk strategy because we don't know that we can ever achieve herd immunity because the immune response might be weak, right? But, it's interesting. So they are saying they're having lots more deaths compared to the neighbors. So compared to Denmark and other neighboring countries combined, they have more deaths than all the neighboring countries combined.
Sweden is having twice as many deaths as Denmark, is my understanding.
That's right. So their argument is we're having deaths now, but then we'll not have the deaths later. Everyone else will ultimately have the same number of deaths, but over a long period of time. So they're saying the curves just flatten. Their curve is steeper, everyone's flattened, but the death's going to be the same long term.
But does Sweden look like what if, as you say, we never get a vaccine? Is Sweden kind of our model, at least our, as you say, experimental model?
I'm not sure that it is.
Okay.
Yeah, I'm not sure that it is. Our model is more probably South Korea, Singapore, probably. So South Korea is opening up. So Germany is opening up. Singapore had opened up, but now have to shut down because they've had a second wave. So our trick is to open up gradually without triggering a second wave. The second wave really happens when numbers keep going up exponentially and you can't control it. So we don't want that to happen. We want the numbers to potentially, it can go up, but in a controlled way. Ideally, not go up at all, right? Not go up at all.
Yes.
Unlikely.
But we might have to tolerate that if there's no vaccine.
I think that's right. At some point, if there's no vaccine coming, we're going to have to live with this. How do we do it in a structured way that's acceptable, without overwhelming the health system? So this is why we are really only allowing 25% of non-urgent elective surgeries to come back. We are still maintaining our additional beds. We're still not, we're still stockpiling PPE. We're waiting for a potential surge. These are all backups. We have to be prepared.
Being careful. So we're running out of time. This was a completely fascinating discussion. Before I let people go, I want to thank you so much, Erwin. And I also just want to remind people that the Australian Intercultural Society is having another conversation this coming Wednesday at 12 p.m. That conversation will be with the Australian Human Rights Commission's Race Discrimination Commissioner, Chin Tan. He'll be in conversation with George Dunekian about racism during COVID-19. Some people may be aware that there has been reporting of racism directed towards Asian Australian communities, particularly the Chinese community, since the pandemic has reached our shores, which is obviously very concerning. So if you want more information about that conversation, please go to the AIS website, which is www.intercultural.org.au. For now, that's us signing off. Thank you again, Erwin. And thank you to everybody who participated and sent us questions. They were terrific. Bye now.
Thank you. Thanks, Leslie. Thank you.